My colleagues and guests, why don't we begin our plenary session? We've got an important discussion this morning on health care and the economy, and we're going to get underway. If I could have everyone's attention.
Feed on something. There you go. Nearly hit it a couple of times.
Ladies and gentlemen, let's all find a seat and begin our discussion of health care and the economy this morning. I want to welcome all the governors back and all of our guests as well. I think this is going to be a great opportunity to have a moderated discussion on health care and its impact on the economy. I'm really pleased to introduce the leader of our discussion today, Maria Bartiromo. You might find it interesting to know that someone who's the bearer of occasionally bad economic news has become a real celebrity in her own right, but Maria has certainly done that. You can see her every weekday afternoon on CNBC giving the ups and downs of the day's market activity on Closing Bell. She's also distinguished herself as the host and managing editor of the Wall Street Journal Report, which is the #1 financial news program in the United States. She's received high honors for the quality of her work. She's considered a true authority in her field. In fact, this past December, she was featured in the Financial Times as one of the 50 who shaped the decade. And we're really fortunate that she would take time on a weekend to be with the nation's governors today. She's a soon-to-be author as well. Her new book is entitled The 10 Laws of Enduring Success. It's out at the end of March, and we'll look forward to seeing her thoughts in this new book. So let's give a great NGA welcome to Maria Bartiromo.
Thank you very much. Thank you very much, Governor Douglas. Thank you for having me. Thank you all for having me. I find it increasingly interesting that as I talk about the economy on CNBC and on the Wall Street Journal Report, almost all the time, health care is part of the discussion, and the cost of health care and its impact on our economy. So I am very pleased to be with you today to try and talk about controlling costs, insuring more, and what we can see happen on a state-by-state level. I thought I would roam today. I'd love to make this conversation as interactive as possible. I have asked some of you to please jump in if you hear something that you agree with or you disagree with, so that we could really have a dialogue here as opposed to a Q&A, me asking each of you questions. And of course, we all know the statistics, and they are not pretty. Healthcare spending in 2007 reached $2.25 trillion. We're talking about 16% of the gross domestic product, and we continue to see a national and really international debate on how we will get our arms around this spiraling expense that continues to hurt our economy. Many of you have seen the impact on very, very important industries like the autos and so many others, and how it has impacted our economy and our everyday life. So, Governor Douglas, let me kick it off with you. Give us the state of state from your standpoint in Vermont, and tell us where you think we can be on a state-by-state level.
Well, Maria, I recall when I took office 7 years ago looking at the economic impact of rising health care costs on businesses and families in Vermont, and the fiscal impact on state government, because it's a large and increasing percentage of state spending every year. And I realized that we had to get those costs under control. There's a lot of debate in Washington and state capitals about how we structure paying for health care in America, whether it's a publicly funded plan or privately funded system. But in the end, I'm not sure that matters, because if we don't get costs under control, if we don't bend that curve that is rising in multiples of inflation every year, we're going to be broke either way. So we put in place what's called the Blueprint for Health, a strategy of preventive care, of managing chronic disease, of screening for chronic illness, of wellness, of good nutrition, and over the last 6 or 7 years, it's paid off. We focused on our Medicaid population, which is among the highest in the nation. We have 26% of our population on Medicaid. It's going to be 28% next year. So we have to control those costs. And with a waiver from the federal government, we've realized about $250 million of savings in our Medicaid program over a 5-year period through this strategy of managing chronic disease and providing preventive care. It's not something that happens overnight, and I think that's important for the American people to understand. It's about bending a curve and making progress over time. But we've shown over the last 6 or 7 years that it really can be done, And I hope that we can continue to talk as governors about initiatives we've had and ideas that work in our state so that others can replicate them.
Yeah.
And just in the last couple of years, twice now, national surveys have rated Vermont the healthiest state.
Yeah, we'd like to look at some plans that have worked, whether it's Vermont, Massachusetts, and also some plans that may not have worked so well. Governor, let's talk about Tennessee. Let's talk about what happened when you put a plan forward back in the 1990s with all the best intentions, and yet, in retrospect, what went wrong?
We had, this was long before my time, a plan called TennCare. Tennessee in 1994 was kind of the Massachusetts of its day in terms of trying to expand health care through a massive series of waivers with the Medicaid program. We expanded dramatically the number of people on Medicaid by adding a number of categories. The uninsured, if you were uninsured, you could get on Medicaid. If you were uninsurable, you had diseases which caused you to be rejected, you could get on. The problem was, it was just, I guess, the classic business problem that when you add as many benefits and as many people in a quick period of time, the expenses all came true perfectly on target on Monday morning. The savings, which were supposed to pay for all of those over time, not only stretched out a long time, but in many cases did not come to fruition. And we ended up, a decade later when I came in with a system which was just completely on its back. We were spending more money in the pharmacy benefit in Medicaid than we were spending in our higher education system. We were spending more money for one drug on Medicaid than we spent to support the UT Medical School. And it just took, it took some very difficult actions to bring it back, including substantial cuts in benefits, taking some people off the rolls. It was very painful. But I do think there's a lesson there of maybe taking things a step at a time instead of just leaping off the end of the dock when it comes to how you deal with some of these issues.
This is an important point, and Governor Manchin, you said earlier, what is really important is to consider is once you put a benefit in place, it's very tough to take it away.
It's almost impossible. And that's what you'll find most of the governors here that will agree to that. We took a position, Maria, that we had to start with our youngest. Obesity in our children, I think all of our states had problems, but in America it's a problem. So in West Virginia it was a problem. We started healthy lifestyles, trying to get people to where we could spend as much time and effort with a child trying to keep them from getting a chronic illness or a life-threatening illness. And hopefully that would permeate up to their parents to where we could change the whole social aspect of health care. The bottom line, the way we see it in West Virginia, is very few people have a value because they don't pay for it. It's always somebody else that's paying the bill. And when you don't have a value, sometimes you'll overuse it or misuse it. With that being said, and as a cultural, if we don't put as much emphasis on wellness as we do on repairing you when you're broke, the cost can get out of hand. And we think that's what's happened. The consumer is not in the market. It's the only service in America that you and I don't shop. We don't really look at our bill that close. We don't really understand the bills because they keep coming at you 6 months and maybe a year later. And before, all you care about is that I satisfy my copay. I've said something very simple, that why don't we have universal billing? Why don't we all agree that the first piece of legislation we should pass to get the market back and market forces working is that any medical procedure you have anywhere in America has to be a complete, concise, and itemized bill that you and I can understand. So maybe I can ask the question, that 5-minute visit cost me $275. Could it not be maybe a little bit more competitive? And are you sure that pill was that costly? And I don't remember getting that blood test. We have nobody in the market. We're trying to control something that's so big, and we've got nobody trying to help us control it. And everybody's on one side winning, and the other people that are paying, we've always said in the political world, if the constituents, there's no constituents favoring the change because no one really cares. We did something in West Virginia called, we asked for a waiver from Medicaid called Mountain Choices. and we've called it mountain choices. We have a lot of people basically that if you're on Medicaid, you don't get your eye care, you might not get dental care unless it's pain and suffering. But if we said, if you will enter into a healthy lifestyle choice, if you'll go to your doctor's visits and not use the emergency room when it's not needed, you can start earning points and rewards for glasses, for health care. And the cost starts coming down because there's a value. There is that reward system. And we're trying to expand on that. And when you hear us all talk, we talk about flexibility. Because as Governor Bredesen just said, he inherited a program that had all the good intentions. All the costs got loaded to the front end, and then the savings never came from the back end. And everybody else was sacrificing in his society to make up for the costs that they couldn't reduce. We're trying to prevent that. And if you hear us talking, when we say flexibility, before we expand, make sure we can live within our means.
This is a really important point, and you've said a lot of very critical things to the national discussion, about the national discussion, because what we've been hearing a lot about is really health insurance on a national conversation, and not necessarily health care, which is why I'm so delighted and really thrilled that the First Lady, Michelle, has taken on this issue of child obesity, to really get into early on the issues and prevention, and so that we don't spend as much as we do later on in life on these preventable diseases. Thoughts on this issue from the table as far as expanding care and prevention and putting things in place sooner rather than later to get a handle on costs?
Thank you, Maria. Jennifer Granholm from Michigan. We in Michigan, we wanted to model ourselves after a plan that worked, because obviously if you open up Medicaid to anybody who comes, you're going to be taking on a lot of expenses, and so you have to figure out on the front side, how do you do the prevention and the primary care? How do you make sure that people have a stake in this so that there's a shared responsibility? How do you make sure that the benefit package is one that you can afford? And how do you make sure that it's transparent? So we looked at Massachusetts because they had done a huge effort in healthcare reform. And it required some cooperation on the part of the federal government, and there was a shared responsibility both of individuals and businesses and government. And to me, I'd love to hear from Governor Patrick about how that's worked in Massachusetts, because I think that's a model that we can all look at as governors if in fact it's been successful. And what would you change?
We didn't work this out in advance, just to be clear.
No, this is perfect. Thank you so much, Governor Granholm.
But thank you for the setup. We have a hybrid system, as you may know. It's a combination of both market and public contributions. It builds very much on a strong private insurance market. In Massachusetts, it was invented on a bipartisan basis under the leadership of my Republican predecessor, a Democratic legislature, Senator Kennedy, and at the time the Bush administration, which was absolutely essential in terms of approving the Medicaid waiver. And the implementation fell to me starting on the very first day in office, and we have now nearly 98% of our residents insured today. I don't think there's another state that can touch us. Jim Douglas is coming on strong from Vermont.
He's catching up.
He is. He won't catch us, but he is making progress.
We'll see. We'll see.
We had some, just to Joe's point, though, Joe Manchin's point, everybody starts from a different place. Because we were using so many other patches and plugs in the healthcare safety net, if you will, in other elements of the budget. A universal system in the reform that we've pursued has added only about 1% to our total budget. And we have saved in the uncompensated care pool and moving people out of emergency room primary care to primary care settings, which is huge. But the big pickup and the remaining challenge is cost control, and that's not unique or even special to Massachusetts. That's everybody's issue. And to the premise of your question, your last comment about prevention, That's an absolutely critical part of it. There is a responsibility, and as we talk about shared responsibility, there is a responsibility that individuals and families must take around wellness so that we can move to a health care system and away from a sick care system, which is what we have today. We have some ideas around cost control, particularly around payment reform, that we're looking to implement right now and that we talked about in yesterday's session. But it cannot be understated the importance of each of us doing what we can to look after our own health and our own healthy choices.
You know, actually, Governor Manchin made a good point, because in other areas of our lives, there are repercussions and implications for your behavior. You know, in car insurance, if you get into a lot of accidents, your insurance goes up. So the point that you make is duly noted, really, really important. Governor Pawlenty.
Thank you, Maria. Just some things that have worked in Minnesota that may be helpful for the discussion. One is we have the highest concentration of health savings accounts in the country in Minnesota. And for those who participate, we've been able to document some relative savings, which has been a good thing, and they've helped contain costs in our state. We have another program that we've put together with our state employees around payment reform, and we've said, look, people tend to spend money differently if it's their own money, or at least some of it's their own money. Now, they need to have guardrails in place for consumer protection, but we said to our state employees, you can go anywhere you'd like, but if you choose to go somewhere that is poor in quality and high in cost, you're paying more. And if you choose to go somewhere that is more efficient with respect to costs and higher in quality, you'll pay less. 90% of them, 90, have migrated to higher quality, more efficient providers. And in 3 of the last 5 years, the premium increases in that program have been 0%, and in the other 2 years, close to 0%. And that's on fairly primitive measurements of cost and quality, and the ability to make that even more advanced is progressing very nicely. So we're going to have even better look into that in the future. So that has worked nice. We have another program called Q-Care, which we've said for all of the public programs that we pay for health care, we're going to begin to pay for performance. We're no longer going to pay just for volumes of procedures. In diabetes and heart disease and some other chronic care conditions, we expect the practitioners to follow best protocols and achieve better outcomes, and if they do, they get a financial bonus, and that has some early promising results. And then lastly, in the medical malpractice area, there's lots of ideas for reform here, but clearly some improvement can be made. We have a system that says if you're going to sue a health care provider, a doctor, for medical malpractice, you have to submit an affidavit at the front end from another doctor in good standing in our state, indicating that there's reason to believe malpractice occurred. And now we'd like to take that to the next step, where it's not just a doctor, but a specialist or a subspecialist in that same area, if it involves a specialty practice, making that same affidavit. That's been a very good gatekeeping role to try to minimize or at least reduce frivolous lawsuits. And then lastly, I'll put a plug in for what Ed mentioned yesterday. We know in other areas of insurance, like life insurance, again, assuming consumer protections are in place through a compact or otherwise, that competition is a good thing. In many states, there's very little choice about where you can get your health plans. In my state, 3 health plans control almost 90% of the market. They really don't compete very vigorously on price, and I don't think that's robust enough competition. So I think it would be very helpful, like with life insurance and other forms of insurance, if we could have our citizens have the chance to choose from more options across the country, again, with proper consumer protections in place.
And it's really interesting how there have been great successes in certain areas, and in other areas, programs have fallen short, because one size doesn't fit all, right? I mean, the demographics of the states are different. And so while we should be looking at some things that we take away and use all of us, there are also lessons to be learned.
On that point, we have failed on many of our government entitlement programs. They are out of control. We have publicly subsidized health care programs that were growing 30+% a year, but they are the old model of fee-for-service, meet certain retirement, show up, we pay the bill no matter how many show up and what the bill is. Those models are rising so quickly in our state's budget that we can't sustain them. So the ones I pointed to are successes, but we also have our share of programs that are financially out of control.
Governor Barbour.
Thank you, Maria, for taking the conversation this way, and for Joe and Jim, because I really do think that we need to recognize the states are a big part of the solution. In my state, when I became governor, Medicaid spending was going up more than 20% a year. My first 6 years, it went up less than 2% a year. One of the ways we did that, we got control of our pharmaceutical benefit with the PDL. We've gone to about 75% generic. Secondly, we have face-to-face redetermination for eligibility. And one of the things that results from that is just last week, CMS said our error rate in Medicaid is 0.13%, which they've only audited 17 states so far, but I don't believe anybody will beat 0.17%. Now, let me put it in focus with the other side of that coin. Robert Payer, the health reporter for the New York Times, is probably the #1 health reporter in the United States, wrote an article last month about health care spending taken from the federal government's numbers. Said that private health insurance premiums in 2008, the last year we have figures, went up 3.1%. Private health insurance benefits went up 3.9%. Cost of Medicaid went up 8.4%, and the cost of Medicare went up 8.6%, which is why I'm so excited y'all are talking about what states can do, because those numbers don't convince me we ought to turn this over to the folks that run Medicare.
Thoughts? Governor Rendell.
Maria, I want to go back to what Tim said. We're looking for common ground here in this health care debate. And everyone, Democrats and Republicans alike, say we've got to get competition into the marketplace to drive down costs. Well, the idea that Tim came up with is a good idea, and one that most of us could sign off on as long as they're the right protections. For example, I have nothing against an Idaho company coming in and selling in Pennsylvania. It would help competition. But, and this is an important but, they've got to adhere to Pennsylvania standards. For example, we require health insurance companies to provide aid to autistic children and families. Other states may not. So the way to get around this is the way we do it for life insurance. We have a model compact which sets standards. States can sign on to that model compact, and if they do, then you're a health insurer, you can go into any of the life insurer, you can go into any of those states and sell your product. We could do that. It would be non-controversial, I think, and it would help us lower competition. It's not the only way to lower costs through increased competition. It's not the only way, but it's an important way. But I think if you went around the room and talked to all 53 of us, you would find that there are common sense ideas everywhere that can cut costs. And one of the things that I think we've failed to do federally is enough cost cutting in the bill itself. For example, I'll just take one, and I know my colleagues can throw in many, but emergency room costs. We know that the emergency room is the most expensive venue in the whole healthcare delivery system. How do we cut emergency room costs? Well, people go to emergency rooms because we've designed a healthcare delivery system that's open from 8 in the morning till 4:30 in the afternoon, Monday through Friday. Anytime else, even if you have non-critical problem, you have to go to an emergency room. We in Pennsylvania are starting to require all of our emergency room facilities to have a non-emergent care facility open 24/7. And that means it's staffed by a nurse practitioner, a physician assistant, and they can administer the stitches that are necessary to close a dog bite wound, and you have no waiting, and it's you're getting billed for physician's assistant time instead of a doctor's. Boom, bingo. 33% of the cost. Non-emergent 24/7 rooms can be a big answer to the overload to the system and the costs of emergency care. It didn't take a genius to figure that out. And I think that's true with a lot of cost-saving ideas in chronic care, hospital-acquired infections. Every state, we lose, the healthcare delivery system loses billions of dollars a year for the cost of a hospital-acquired infection. Average hospital stay is about $30,000 in Pennsylvania. If you get a hospital-acquired infection, it's $185,000. So we've got to cut down on hospital-acquired infections. There are simple protocols which can cut them down dramatically, but we haven't put them in place. In Pennsylvania, we're starting to. So there are 1,000 good ideas out here among the 50 states, and we haven't taken a look at them.
Do you think that people, though, are going to be worried about the quality of health care in the scenario that you're talking about?
Well, the good news is cost savings improves quality in most cases. For example, in that emergency room thing, if you go in with a dog bite now, Maria, on a busy Friday night in Philadelphia, they'll say the most dreaded words known to human beings, "We'll get to you as soon as we can." 4.5 hours later, a doctor, a high-priced doctor, cleans out your wound with mercurochrome, stitches it. If you had a non-emergent care 24/7 facility, a nurse practitioner does it in a half an hour. Hospital-acquired infections, if we make hospitals do a better job policing them, it saves lives and saves horrible health outcomes.
Governor Herbert.
Thank you, Maria. As one of the newer governors here, it's my observation that I think in the national health care debate, the state's significant role has been somewhat forgotten here in Washington. I think, as Governor Patrick has mentioned, we all start from maybe different places in our own experiences and our own unique circumstances. We followed what Massachusetts is doing with a health care exchange in Utah and did it just a little bit differently with the idea of trying to come up with a defined contribution as opposed to a defined benefit. And working with our small business people, they're really having a hard time with their bottom line and having predictability because of the rising cost of health care. With a defined contribution, they now have predictability that's entered into. Then we've opened up an exchange where the consumer, the employee, actually takes this defined contribution and can go shopping. It's like a Travelocity.com window that's opened up, and they can take their dollars, if that's $700 or $800 a month, and see what they can find in this window that's uniquely suited for their own circumstances. So there's nobody that manages with money better than those that control their own dollars, and so it's a win-win for the employee and for the employer. We've opened up in August 9th of last year. We now have a number of small and larger businesses with over 40,000 employees that are now impacted with this opportunity. And it's introducing competition. Now insurance companies are trying to find the right policy to attract customers. And although I don't know that it's anything perfect by any means, it is the first steps in a longer journey. At least we in Utah are trying to put together a 10-year health care reform plan to see what we can do with the states taking the lead as opposed to waiting for the federal government. Again, I think states are uniquely suited to do this. We're a lot more nimble. As we find problems in the reform efforts, we can change and modify. We are a lot easier at finding those things that will serve our public and our constituents better, I think, at the state level. So, again, last but not least, our approach is pretty inexpensive. We only have 2 employees, 2 staff people to manage this exchange. And so it's very cost-effective in our early beginnings and is introducing competition and lowering costs for the employee.
Thank you for that. Governor Lynch, and then we'll...
The question that you asked, I think, is a fundamental one that we need to discuss. And the question is, can you stabilize costs or lower costs and not affect quality? And I would contend that we can do that. I think technology is an important aspect, an important element of how we deal with the cost in order to make us more efficient. Technology should be able to do for healthcare what it has done for virtually every other industry in the private sector. It ought to be able to improve quality, improve customer service, and stabilize costs. And that means providers being able to prescribe medication electronically and evolving toward electronic medical records. Transparency is something that was discussed yesterday. We need to continue to push transparency in all that we do, not only around cost, but also around outcome. In New Hampshire, we're piloting medical homes, similar to accountable care organizations that, again, were discussed yesterday, evolving away from fee-for-service and more toward total care of the patient. And obviously, stronger focus on prevention and wellness. In New Hampshire, my wife, Susan, who's a doctor, she specializes in pediatric cholesterol management, initiated a program years ago called Walk New Hampshire, getting school kids to walk a distance over time equal to the length of New Hampshire, 190 miles. You know, Governor Plenty talked about a number of initiatives in Minnesota that I think are very important ones. But I think it's an important issue that we need to see if there's a consensus as to whether or not we can stabilize costs or lower costs and still not only keep quality high but improve quality.
Maria, let me offer a couple of thoughts on some of the issues my colleagues have mentioned. We have to, I think, reform how we deliver care. It's not just about money, and if we make the kinds of reforms that we've discussed this morning, we can indeed get a handle on those costs. The medical home concept that Governor Lynch mentioned is something we're doing in Vermont and other states are. I was pleased that Secretary Sebelius announced that Medicare very shortly will begin some pilot programs to participate in that strategy, because we have to have all the payers, public and private, at the table. And that leads to another important element of what we need to do, and that is change the way we pay for care. Now it's volume driven. We pay for procedures and tests and drugs and admissions. We pay for stuff. We don't pay for outcomes. We don't pay for the quality of that care. And we have to align that, I think, if we're going to make progress on quality improvement and cost containment. So what we do in Vermont is pay an incremental amount to our medical home primary care practices on a per patient per month basis if they adhere to certain national quality standards. And that's the kind of incentive that works. It can be significant in a practice with several thousand patients. So if we align our payment with the outcomes we want, I think we can get a handle on the cost of medical care in our country.
Paying for outcomes and only or mostly, and not for that volume that we're doing right now. We're going to go to Governor Perdue, and then I'm coming back to you, Governor Manchin.
Thank you. We pay for outcomes in North Carolina, too. We are one of the initial states that began the medical home. But in our fourth or fifth iteration, and we've just gotten one of the 646 waivers in North Carolina to provide the managed, if you will, Medicare care. We believe that a medical home has to be much more comprehensive than just a primary care provider, although that's the onus of care. That's where you start. But then we have a network of community care providers, Maria, anchored with a case manager, so that if I'm a Medicaid recipient, I don't necessarily go to the doc initially. I use my case manager to put me in a wellness program to help manage my asthma or my diabetes. We are not only bringing down the cost of care in North Carolina for our Medicaid population, and I believe for soon to be our Medicare, we are actually trying to make sure the services that our patients receive are the services they need, and then front load the system with a complete community-based wellness initiative so that folks do realize it's how they manage their disease. I don't believe you can just provide a medical home with the doc. I've never believed that. I think you've got to have that comprehensive array of services from the moment of entry into the system as you navigate through different levels of acuity and care to the ultimate outcome for us, which is a cheaper benefit with a healthier citizen.
Maria, the greatest savings that I believe that all of us could prosper by is the technology, and Governor Lynch just mentioned that. We have telecare, health information technology, but the exchange of this technology, the administration, the Obama administration, predicts that there could be as much as 30% savings. 30% savings by this type of technology and exchange in my little state would be $3 billion of health care savings. That means $1 billion of savings just in my Medicaid program.
How is it saving so much money?
Well, basically what you have is the unnecessary tests and prescriptions, the redundancies, the mistakes, the lawsuits, it just keeps piling on. These are things that we could all have tremendous savings immediately from. We seem to be bogged down in debate how we're going to deliver it and who's going to be the winners and the losers. But we all win on this one, Democrats and Republicans.
Governor Ritter.
Thank you. We adopted a sort of a way of going about this called Building Blocks to Reform. We had a commission that said the least expensive statewide plan we could implement would cost us $1.2 billion. And people in Colorado think the system's broken. We're not going to put another $1.2 billion into a system that was broken. So we've gone about it in a step-by-step fashion. What's interesting as part of this conversation is almost everything that's been mentioned we are working on. We have an initiative on, and there seems to be a great deal of consensus among states about the things that are necessary. We have a technology initiative. We have a transparency. We have a hospital report card. We have medical homes for children. We have both delivery and payment reform that we're working on. We did tort reform in 1988, before it was cool. We put in place caps on non-economic damages, and on economic damages we've only changed it once since. So it's not, tort reform is not the big enemy in Colorado, and yet we are the 7th most expensive state for health care. And so with all of these, we have an initiative currently looking at the value of care, and I think I agree with what Governor Rendell said at first about this relationship between cost and value. There really is the quality of care, that you can improve the quality of care and actually reduce the cost in doing that, and we really need to focus on that. But one of the big cost drivers for us has been uncompensated care. Our inner city hospital did $375 million in unreimbursed care last year, the Denver Health System. So what we did was pass a thing called the Health Care Affordability Act. The more you treat Medicaid patients, we put in place it's called a fee. Every patient bed, there's a fee, a provider fee that's paid in. The federal government matches what goes into that. And so if you are providing care for unreimbursed care, then you're going to get additional money. And if you're not, you're going to be paying into that fee. And we're going to cover 100,000 people with doing that. So the last thing I would say is, with all of this sort of consensus, that there does seem to be about these things that would drive down cost and also help us focus on quality of care, we have to be able to get to some common ground that they've been unable to get to here in Washington, D.C. Right. That's just, it strikes me that this is something we can't fail as a country. If we fail to do it, I mean, we're in really big trouble, because the amount we'll spend on our GDP just makes us not competitive, and yet we have things that we, I think, can come to some common ground on, and that may be what's necessary to form the basis for a bipartisan solution to health care.
Yeah, I mean, we face these dilemmas, and it's going on in other industries as well, whereas we want the services that are so important to our people to be low in cost. We want them to be available. We want everyone to have access. And it's the same as banking, plain vanilla banking and our deposit money. And yet, many of the companies that are in leadership positions in these areas are looking at shareholders, facing a different constituency in terms of making sure they have revenue growth, profitability, and yet, from the other side of things, we need their services to be there for the people. So we are really in a very, very interesting time right now, and it's creating amazing dilemmas. Yes, Governor.
Well, yesterday, Maria, we heard from a couple of wonderful physicians and authors that I think answer your question about can we increase quality and reduce costs. When I first came into office in 2005, Dr. Halverson had written a book entitled Epidemic of Care. There was a study done that I think is most telling. Approximately 115 physicians were given the same patient with the exact same diagnosis. What was interesting about it is back came 80 different treatments. Now, clearly, some of those were effective, but by and large, many of them were not. Thus, outcome for patient poor, cost dramatic. So among the things that Governor Ritter talked about, we're trying, but one is a panel of experts that are looking at common diagnoses and asking what is the most effective treatment, and we're not doing it based on cost. Because if in fact the treatment works better, it costs a little more, it's better than other treatments along the way in search of that ultimate positive treatment. Back pain is a perfect example, where all too often in certain segments of my state and of the country, you will find doctors who immediately resort to a surgical procedure, which is very costly, yet the outcome for the patient is no better than physical therapy, would be much less intrusive, and the patient is served better. So when we talk about what Congress is doing versus what we're seeing, the frustration I think we share is we want real health care reform. It's not about health insurance reform. It's about health care reform. So things like point of service, things like getting better quality care at a reduced cost to patients is really where we think we ought to be headed.
And the 24/7 care.
Correct.
Even if it's not a doctor necessarily doing, lower type procedures. Yes, Governor Markell.
Thank you. And first of all, I want to thank Governor Douglas for putting this together. I think this has been a great conversation, and I've taken very careful notes based on a number of suggestions from my fellow governors. And I really just have another question, and it has to do with long-term care. And I'm wondering whether any governors have had any particular success. It's obviously a hot issue with an aging population in our state. It's a particular issue. We've got a very rapidly aging population because we have a lot of retirees moving in thanks to our low property taxes. And there's been a lot of discussion about having people... That was a little plug. Yes, that was a little plug. I thought I was being subtle. But the point being, there's a lot of talk about having people not go into the very expensive institutions and having them serve more in the community. And yet some studies would suggest that in the end, although there's a lot of promise that costs get lowered, they're not always delivered, sort of along the lines of what Governor Bredesen was talking about. And I'd be interested whether any governors have come up with anything specifically with respect to long-term care.
Anybody? Governor Rendell?
Yeah, we've had a great success transitioning people out of nursing homes. Right now, nursing homes in our Medicaid program is our single biggest cost driver. We're a very old state. It costs us almost $30,000 a year for one person in a nursing home. For a family of three, a young mother with 2 children, it costs us about $3,200 a year in the Medicaid program. So to take that individual out of a nursing home, put them in home care, is, number one, in most cases, what they prefer. Seniors prefer that. And number two, it's a significant cost reducer. There's some upfront costs in the transition, but you reap the savings fairly quickly. And by the way, Pennsylvania doesn't tax retirement income.
Maria, we have a program in Vermont called Choices for Care, and it has resulted, as Governor Rendell suggested, in real cost savings. We got a waiver from the Medicaid authorities to offer equal access to at-home care as institutional care. And we've de-licensed several hundred nursing home beds around our state, which is significant in a small state. And we've saved literally several $1 million in our long-term care Medicaid budget as a result of this effort. And Ed's right. That's where people would rather be, at home, cared for by either their own family members or professionals in their home. So it has worked, it can work, and this raises another important issue, and that is flexibility, because we had to go to the folks in Washington and get a waiver and go through an onerous process of applying for it and amending it from time to time. What we really want and need, I think, from the federal government is flexibility to do it our way, and that alone will save costs.
That's an important point. And more success stories?
Yeah, let me just
to
say,
answer Governor Markell's question?
Yeah, Maria, let me add to what's been said, because to Jim's point, one of the things we did in Rhode Island is before the end of the last administration negotiated a global Medicaid waiver. And the premise behind that was to allow the state to have more flexibility, more control over exactly the kinds of issues that Jack has brought up. It has been enormously successful. We're in the process of implementing it. All the savings that Ed, Jack, Jim have talked about, we are seeing the diversion of people in a nursing home. Most elderly people prefer to stay in their home. There is no support mechanism, particularly for those eligible for Medicaid. We've all had to go and get individual waivers. So we negotiated a global waiver, allowing us as a state to manage that, and it's been enormously successful. We're saving tens of millions of dollars. We've diverted hundreds of people. Some who were already in nursing homes didn't need to be there and chose to come out. But you need to develop within the community the support systems that are there so that you can give them the kind of support that they need to either stay in their home or an assisted living or some kind of intermediate facility. But clearly, for all of us, that's a huge part of the Medicaid expenditure, and it's going to grow as the population is aging.
Governor Heinemann.
Maria, I want to go back to where we were talking about technology, and you see this every day. You report on it in the financial sector, and several of us around the table have been state treasurers. Funding, information, all of it moves electronically, real time, every day. If any of us want to go online right now and find out how much money's in our banking account, we could do it. How much we owe on our credit card. If we wanted to go online right now and find out anything about health care, particularly as it relates to us individually, we can't do it. We need a comprehensive electronic medical system that connects doctor's office, hospitals, pharmacies, the entire system.
Which opens up, though, a can of worms on privacy, doesn't it?
It does, but we've got a situation going on in my state right now where we're conducting a pilot project in that regard in the sharing of information. You have to opt in. 98% of our citizens have opted in. It's up to you. You've got to say, in terms of privacy, we can provide it, and your records will be secure. But if any of us around the table today had to go see a doctor, they would start over. We can't afford that. We ought to be able to share those records. We ought to be able to share our prescription data, assuming we agree to it. And that could drive down costs significantly, eliminate duplication, and a number of things.
Following on that point, that's very real. In North Dakota, we've had people that go over to the Mayo Clinic and then to take all their records with them. Yeah, I knew you'd like that, Governor Plenty. It's a real challenge, a real difficulty. So it's not only a cost savings, it goes back to that quality of care. The point I wanted to make, though, is Governor Markell talked about or was asking about ways to save costs in long-term care. One of the things that we found is most productive and helpful in that regard is providing incentives for individuals to purchase long-term care insurance. Creates the right kind of incentives, so both tax credits on the front end as well as sheltering their assets that they can then pass on to family members is a real incentive to buy that long-term care insurance. That's very effective in terms of cost savings for the state, but also very good for the individuals and their families.
If it can be shared. If it can be shared, the insurance, it can be passed on.
Well, what it does is, in essence, then their insurance pays for their long-term care rather than Medicaid. So it's tremendous cost savings to the state. The other types of incentives are incentives that encourage family members and others to take care of individuals, home-based care and community-based care, rather than going into institutional care. And significant cost savings can be achieved that way as well.
Yes, sir.
Maria, John Baldacci from Maine. I just wanted to point out that in all of the discussion, what seems to be lacking sometimes is about the patient themselves, the consumer, the individual, because I think we have a sense as governors that everybody's got a responsibility, including the patient. And I think bringing them into the discussion and making part of the decision-making, what we've done in our state is we've focused on primary and preventative health at the local level. We use our tobacco funds to have 34 main healthy partnerships throughout our state, which are at-home visits or primary care or preventative care. And also we've used a ITV network where people can log on to from anywhere in the state and do their own health risk assessment, sort of, and be able to, at the end of that, to be able to plug them into local resources so that, you know, while all the debate is going on, at least people begin to take tools on their own that are there, that are either free or reduced cost, and they know where it is, because there really is a lot of confusion to the layperson as to where to go for care and what care is available. So it's part of a beginning education program, and I think that needs to be done more of nationally, though, too.
Well, it seems like the tools are in place for states to really control some of this cost, and yet we still want more progress. Jennifer Granholm, how much of a factor was rising health care to the, I don't want to say demise, but upset in the auto sector?
You know, Maria, a couple of years ago, Lee Scott, head of Walmart, came and spoke to the National Governors Association about the importance in a global economy of having a uniquely American solution to the cost of health care, because in a global economy, our competitor countries are providing health care to their businesses, and that puts a disadvantage on ours. The auto industry is the poster child industry of an older legacy business that has been significantly impacted negatively by global competition because of the cost of health care.
So you're saying the Japanese, the Chinese, they have better health care costs?
They have a better cost-sharing arrangement with business. There is no doubt about it. And so we hurt our businesses. This is exactly what Lee Scott was saying. It's one of the reasons why initially in this health care debate, the Chamber of Commerce was on board with finding, again, a uniquely American solution. Now, this doesn't mean, I've been listening to all of us here talking, and there's a lot of great ideas that have come from the states. I mean, here's an example. Governor Douglas and I, when we first came on, we teamed up to pool our buying power to get rebates on prescription drugs. That power of largeness is really an important way to reduce those costs. Everybody has agreed, I think, here that they'd like to see flexibility, that they'd like to have managed care in some way so that you don't have fee-for-service that's driving up the costs. Everybody has agreed they'd like to see the states have more impact on being able to drive those costs down, that we'd like to see the experts listen to in terms of what are best practices. People want to see transparency in healthcare IT, both from the consumer point of view as well as the ability to use IT to reduce the costs. We all agree that we want to see competition, which includes a good part of this being driven and operated by the private sector. We all agree that there should be incentives for outcomes, both for the doctors who were awarded for achieving healthy outcomes, as well as for individuals making decisions about their own behavior, that perhaps their costs are less if they engage in healthy behavior. We all agree that there should be, I think, a primary medical home that people turn to. I think we all agree about the shared responsibility that it's government, individual, and business, that everybody has to have some skin in the game. We all agree that there are creative solutions like pooling that could reduce the cost of health care. We all agree, I think, that there shouldn't be automatic denial for pre-existing coverage, and I think we all agree that it would be best if we could cover as many people as possible so that we don't jack up the cost for subsidizing those uncompensated care. These are basic principles that I think most of us could agree on and sign onto. And these are the kinds of things that could make businesses in America competitive if we were to come out with a health care plan that was a no-frills benefit plan that provided flexibility and options but didn't put the entire burden on the back of business.
Governor Pawlenty?
Well, I think the auto industry may be instructive by analogy for other reasons as well. Just to move away from that specifically, but what you had was an entire industry that over time, management and labor together, bargained up the price of their model, the cost of their model so high that it could no longer be sustained by any reasonable projections on revenue growth, and largely insulated from market forces and entrepreneurial dynamics. I mean, Peter Drucker, amongst others, studied General Motors and other companies over the decades and said, it became what used to be a dynamic industry with entrepreneurial spirit into basically a mindless bureaucracy, insulated from market forces. So I think those lessons and the ghosts of the past in that industry, hopefully better now going forward, is instructive for what we've seen in the legacy system that is large command and control, one-size-fits-all legacy systems in government, including entitlement programs and the mentality that's underneath that. We know that individual responsibility matters, markets work, price and value matters. If you give people good information with protection to shop, those kinds of things help. And those dynamic qualities are largely missing from one-size-fits-all bureaucracies. In the case of the automobile industry, they get to run to federal court and get restructured by a judge. They get their pension plans restructured, their health care plans restructured, or there's some extraordinary intervention by the federal government. But the states don't have the ability to do that. We don't want to do that. But I mean, how does our entitlement legacy structures get redone? It isn't going to be by a bankruptcy court. I hope not. So dramatic forces or events have to intercede, because I think we had the same legacy mentality in looking back as General Motors did or the automobile industry did.
It's a really good point. Governor Rounds.
Thank you. I think Governor Pawlenty and Governor Granholm have both hit on something that probably leads us into a discussion about what is going on in Washington with regards to the existing proposals in health care reform. The federal government finds itself in the same position, perhaps, as the auto industries have. You have a promise of entitlement programs, which I think we all recognize government can't continue to pay for. sustainability of health care on behalf of the federal government and the required co-payment on behalf of the states is greater than what we can afford. In doing so, one of the ways in which we now manage Medicaid is by reducing the amount that we pay providers. In the upper Midwest, we reimburse at between 50 and 52% of the billed charge. Now, if a physician is getting paid 50 to 52%, or a hospital 50 to 52% of an increasing number of individuals, because Medicaid numbers are increasing, particularly during a time of a recession, you then have a cost shift onto the private sector, which then drives up the cost of health care for the other industries that are trying to employ individuals. So we now have the beginning of a death spiral with the very basics of our entitlement program. It's not something which was started by this administration or the last administration. It has been going on literally for decades. But now, in the middle of a recession, it has pressure being brought to bear on a system which really is not sustainable. And as long as we continue to look at solutions that would add more individuals to a government-paid system which doesn't properly fund the full costs of care, you're going to continue to make it more expensive for the private sector to be involved in picking up health care as they have in the past for their individual employees.
You know, it's a fascinating thing that's happening here, because you've got the entitlements that are so expensive, and yet they are not, the fundamentals that require those entitlements are changing so much. We're living longer. We are not retiring at 65. I mean, when you look at Social Security, obviously that has been pushed out a couple of years, but it seems like the fundamentals sort of requiring and as the backdrop of the entitlements have changed so much, requiring change of paying out the entitlements. But of course, very few people believe that we'll actually see a substantial change in the entitlements. Is that a fair statement? I know that. Governor Barbour, go ahead.
Well, Maria, if we don't see a change and some control, then we're going to be so deeply in debt. I think the figure is by 2020 under current policy, 90% of federal revenue will go to pay interest on the debt that we would be borrowing to pay for these entitlements. And obviously, as you know from what you do for a living, there comes a time when people won't buy you paper.
Yep.
So something's going to have to happen sometime.
Oh, people have definitely stopped buying papers. Speaking
Maria?
to the technologist in the room.
Maria? I think,
yes.
Over here, sorry. It strikes me as I listen, because having spent most of my career in the private sector, you know, we've all identified cost, and the inflation rate of healthcare costs is the number one issue we all face, whether it be state budgets or businesses, etc. You know, when you look at from a business model, the drivers of cost are volume and price. And what we have here is, when you listen to a lot of what's being discussed and some great things happening in individual states, and frankly all states, we are all working on issues around the cost and the delivery system, etc., all the things that you're hearing here. I said the session earlier, the first session that Jim hosted here, you know, who has the incentive to control the cost? You know, we almost got a cost-plus system here, that nobody seems to have an incentive to control the cost. At the end of the day, the person that ought to be controlling it is all of us, and as individuals. And part of the problem has been there hasn't been enough of a buy-in and enough of incentive for individuals, because the data I've seen that 75 to 80% of the cost of health care is disease that is preventable, or the onset preventable or delayed, if people took, you know, more responsibility for their own health care. All of the issues around wellness. And I know this is long term, but we got to get at that. One of the things we've done in our little state, for state employees, put in place a $500 credit off of their share of the health care premium if they do certain things. Fill out a health assessment form, go see the primary care physician at least once a year, get in a weight management program, smoking cessation, whatever it is, a whole series of these things. The only way we're going to lower utilization, all right, as we age, is to have people take better care of themselves and be incentivized to do that. And I think the biggest incentive for people is they see some money in their pockets, some savings from doing that. Nobody wants to be sick. We know that. All right, that ought to be the incentive. But we've gotten used to, as a nation, that if we get sick, we got the best system in the world that's going to make us better. And what we need to do is, change that mentality to say we need to do things as individual citizens to take better care of ourselves and hopefully delay. And then we need the system to support those kinds of things, the management structure, if you will, to support the kind of care that's necessary. That's the only way we're going to drive utilization down or slow it down, if you will. And that's one of the key drivers here in terms of what's pushing the cost up, as well as the cost of the system.
It's a very important point, and I guess it was, we did a special on this at CNBC, and one of the attendees said that an obese person will cost a company 4 times what a smoker will cost the company, because that person may develop heart disease and diabetes. So it's the incentive program is certainly what we're all talking about. Governor Rendell.
Yeah, I want to go back to what Haley said. At the risk of losing my card as a Democrat, I want to agree with Haley. He said right. We have no choice but to deal with the entitlement question. And the only way we're going to deal with it is if somehow, some way, and maybe it's the commission that the president's going to appoint, if we can deal with it without getting it into the political system. If you look at the current debate, the president's plan says it will save $500 billion out of the Medicare system over the course of time. And that's been turned into a political football. And yet we all know we can and should reduce entitlements to some degree. And we've got to get away from the politics of this game, or else we're never going to solve this problem. And it has to be Republicans and Democrats standing up together and saying to the country, look, we don't agree on a lot of things, but this is one thing we know, and we have to do it. And is there going to be some pain to it? Gosh, in the last 2 years, everyone at this table has administered a lot of pain to their citizens, not because we want to, but because we had no choice. And we've got to get down to the business of making real decisions for the country that are going to set us on the right path. And we've got to have people willing to accept a little bit of political peril, or else we're in big trouble.
I think we all agree. Governor Bredesen.
Just to add to what Ed said, this all is happening today in the context of things going on in the Congress. I mean, this is not a discussion in a vacuum here about what we might do about health care. There have been some of us who have been working on trying to put together some common stuff. I mean, Jennifer, you railed off a long list of things we all could agree on, but it was our experience we couldn't agree on. And I think Mike would agree with that. And I'd like to just, with Jim's permission, I would like to just ask people, are there things of this group around the table, are there messages that we could send as the NGA about, as you consider this, we're the ones who've got our feet on the ground and out there and trying to actually run these things that we could inject into the discussion?
Phil, over here, Maria.
Yes. I'm sorry.
Phil,
my apologies.
I really do believe that we have done that if you'll just take a tape of this program and send it to every congressman and senator's office. You're right. When we get into a setting that seems to somehow inject politics in it, like what Ed was talking about, we seem to find that we don't have as much common ground as we thought we would. When we're here not talking as Republicans and Democrats, but talking about the specific progress in our respective states, or the plans that have worked that have been emulated by other states. And then when you listen to Jennifer tick off the list that she ticked off that saw virtually all the heads around the room nodding, and when you get Ed and Haley talking about agreeing on something, it really does, I think, illustrate the fact that governors, and I hate to be too prideful of my colleagues and of this organization, but governors have to solve these problems, really, and balance a budget. And they're doing it in virtually every state, a little bit differently from time to time, and learning from each other and setting a pattern which should and could be followed. There's very little rhetoric in all this stuff that's been discussed here today. There have been specific examples of programs that worked that did two major things. One, helped contain costs. And two, at the same time, as Jim pointed out, or maybe it was Governor Lynch, it actually improved quality at the same time. I mean, you talk about something that's actually ought to be transported into the minds of policymakers on the federal level about things that are going on in the respective states that do work. This program and the examples that have been cited here are things that really do matter and really do create solutions. Are they all perfect? No. And will they all work in every state? Of course not. That's why everybody keeps talking about flexibility over and over. But the fact that the examples that have been pointed out here are real solutions to real problems and starting down a road toward changing the paradigm, if you will, of the delivery and cost of the healthcare system are things that aren't unreachable, unapproachable, unagreeable. There should be no serious contention that partisan politics will be able to derail this. Maybe you just have to do it in a different forum or in a different focus where it's not in the middle of an election year, although that seems to be going on all the time now, where it's not in a forum where people are divided up but on one side of an aisle or on the other side of an aisle. But the solutions that have been talked about here, the specific examples of workable programs have been uttered by Republicans and by Democrats and have been copied by one another for the last several years, and they do work. So yeah, it can be done. I think it can be done. I think we've got a lot more agreement than we have disagreement if we just stop long enough to listen to the litany that Jennifer and that Tim both said a while ago were things that they thought most folks could agree on. And governors do it.
And we do need to get that list of successful examples to the Congress to show what has been working. And by the way, in addition, get that information to the people. Somehow this should be communicated to the country so that people have a better understanding of what works and what doesn't work. Because some of this stuff is not brain surgery. I mean, some of it is very complex. But other things people can understand and they can get behind. But this whole sort of notion of it's just too big to fix and it's just too problematic, you know, people get upset and they think they don't understand it and they'll never get it and then it's over their heads and then they just don't want to talk about it. And so it's a problem. Governor Manchin.
You know, the thing that maybe polarized things, expansion of Medicaid. Since Medicaid came into being in '65, it was never mandated. None of us have ever been mandated to give Medicaid to everybody just because you fall below the federal poverty guidelines. A lot of states can't afford it. But we've always had to balance our budget and live fiscally and be responsible. Now that saying we're going to 133, 150, whatever, really got everybody to say, okay, now you're going to mandate us that we cover everybody, which we all want to. Now, I don't think a Democrat or Republican doesn't want to cover everybody. But if you make us give the same type of service to an unfortunately person who is financially challenged but very healthy, as someone who's financially challenged but very sick, that's very costly. That's where we keep talking. Flexibility, flexibility, flexibility. One size doesn't fit all. What I do in West Virginia is not probably what Jennifer's going to do in Michigan.
Right, and we all have different demographics that we're talking about.
But what we're saying is we're hoping that the administration and Congress is listening to us because we're going to be the ones saddled with fixing this problem. They might put some guidelines to it, but we're going to have to live within the playing field. And we're saying, get us in the game.
Governor Rounds.
Thank you. And there is one other item that I think most governors agree on, and Jennifer touched on it a little bit, and that is insurance reform. And in that area, in that regard, there are some things that we can do that would dramatically improve the delivery of the financing of health care. Number one is portability, meaning you can move from one group to another group and you don't lose your co-pays, you don't lose the deductibles that you paid in. Second of all is guaranteed renewability for individual policies and for groups so that once you're in it, a company can't simply walk in and cancel. A lot of the states have already done that, but putting those guidelines in place on a national level do nothing except help improve what the field looks like.
But along with that, you also have to include a ratio, so that as the National Association of Insurance Commissioners proposed back in 1993, I believe, that said there's got to be a ratio between your least expensive group and your most expensive group, so that if somebody gets sick, you don't raise the price on that group and run them up so they can't afford it anymore. You've got to have a ratio built in. And those are items that have been proven. They work. Insurance companies accept them. And yet at the same time, if we would do it on a national level, it's something that would assure a more consistent pricing across all of the states. And those are items that I don't think we've had any disagreement on among the governors that are here. And that should be included in any type of a reform package.
Governor Douglas, Governor Manchin, final words?
I could be more proud of a group of people that I serve with and the colleagues that are called governors of the United States of America. And I think you see the common sense and the can-do attitude they bring to the table. And we work across party lines better than any organization I've ever been affiliated with. So I'm proud to be part of this organization and proud to be vice chair of this organization now. But I can only say to the administration and to our congressional representatives that we want to be part of the solution. We want to help find the answers. Because I can tell you, we see the problems every day, and we see it up close and personal. And again, what we're asking for is to have that seat at the table, to be able to bring all this knowledge into the arena to fix the problem that we have. And it's all our problems. It's not just part of the problem, it's all of our problems. So I thank you for allowing us to have this conversation with you.
Maria, you've helped us articulate the tremendous leadership the governors have provided in the states across the country, the reforms that have been put in place, the ideas that have worked, and the differences that those reforms have made in the lives of the people we represent. I hope that these experiences, these examples, these reforms will help contribute to and inform the national debate, because while debate goes on in Washington, health care reform is happening in the states. And we believe we have a lot to offer in this national debate and look forward to being a part of that. So on behalf of the National Governors Association, thank you so much for your contribution.
Thank you very much. Appreciate it. Thank you for having me, and we want to keep you on time. We've heard some fantastic solutions here. We know that the issues are complex, but we also know that there are success stories, and some things are very doable. Thank you for your time today. Thanks.
Thank you all. Break for lunch.